So we are going to start all of this off with where did GLP-1s come from? Most people, especially lay people, don't understand that we've had GLP-1s for more than 20 years. And so they think this is new. We know this is not new, but new is scary to the general public. And so what we're going to do today is talk about the history a little bit, talk about mechanism of action, and what's coming more than GLP-1. GLP-1 is a single peptide, right? You know that there's more than GLP-1. So I'm also going to advocate to change the name. When we came up with GLP-1 Summit more than a year ago, it made sense. It doesn't make sense today, honestly. So currently, we do have several FDA-approved weight loss drugs. Not a lot. Think of how many drugs we have for blood pressure. Think of how many drugs we have for cholesterol. But right now, we really don't have that many for... There's our friend. I'm going to have a necklace made with these colors. I just love it. This is GLP-1. This is our endogenous. This is the structure. These are the peptides that are linked together in that order to make GLP-1. This is the commercial version, though, because of this change right there. That is the change of amino acids that make this peptide slowly broken down by our enzymes. Our own endogenous GLP-1 has a half-life of how long? Who knows? Or has an efficacy, gets broken down within 2 minutes. Yep, 2 minutes. So I present that to my clients as you're sitting at a nice dinner with friends, you eat, and you're like, oh, I'm so full. But then the conversation continues, and all of a sudden, you're not that full anymore. And you're picking, and then all of a sudden, all of your food is gone. That's because your GLP-1 is gone too. So this little change makes the half-life 7 days. And so that's why we can do it as a once-a-week injection. So it's found in the 80s in the saliva of the Gila monster. The Gila monster kills their prey by giving them pancreatitis. And so they said, how on earth does this little lizard give their prey pancreatitis? And they found GLP-1. Good news, bad news, right? And then who thought, that, oh, let's give this to humans. This is amazing. Really? That would not have crossed my mind, honestly. So we know then, but we know the action. It stimulates insulin secretion. It's called a nutrient sensing hormone. And so is GIP. So kind of, you'll hear that term out there too, NUSH, N-U-S-H, nutrient sensing hormone. That means your body senses the nutrients, and the L cells in the intestine release GLP-1, in the intestine, release GIP. 2025 is your first twice daily FDA approved GLP-1. Then we got to the once daily, and 2014, 2016 right there, your first once a week. Super busy slide here, but this just goes to show how much is happening in the industry. This is pretty much our pipeline for weight loss medications. What's coming? There's a lot coming. There's IV, there's oral, there's patches, everybody's trying to make everything, right? So your triple agonist, retatrutide, due to be approved and already in phase 3, due to be approved next year. Cagrosema, anybody heard of that? Cagrelintide and semaglutide. Cagrelintide is a super strong appetite suppressant and amylin analog, and biologics, including IV. I don't know, I struggle with that one because if you can't get your clients to do a once a week injection, you're gonna get them to do an IV. I don't know. So here, anti-obesity medications and nutrient sensing hormones. So I think that the nomenclature is gonna have to change. We have to get away from GLP-1 and do anti-obesity medication. I don't like the term weight loss. I prefer fat loss. Like I don't know what we're gonna end up calling it as a common nomenclature, but GLP-1 is like calling every pill Tylenol. So a lot going on. Here's your top 6 to be 5 coming in the next year. So retatrutide, of course, on the list. All GLP-1, Cagrosema, there it is. Maritide, GLP-1. Maintains weight loss post-treatment. So that's going to be an interesting one. So do you have them reach their goal? Did it switch them? That's like always a huge question. What happens when you get to where you want to be? And then the yet to be named triple agonist. Mechanism of action, we talked a little bit about that already. Your food you have your food intake, it's sensed, so to speak, by the intestines. The L cells and K cells release GLP-1 and GIP. DPP-4 activates GLP-1 very quickly, and then it promotes the pancreas to secrete the insulin to deal with the glucose we just took in. So I do not like to hear, oh, it just makes you not hungry. That's how GLP-1 works. There are so many mechanisms of action in GLP-1. It is more than just doesn't make you hungry. And that's another thing going through this, we'll be able to articulate to our clients that it is more than just, I'm going to take this and not be hungry, eat less, because eat less is not always the goal. Here's the money slide, you guys. Take pictures, pull out your camera, look it up. There's the reference right there. This was my aha moment when I saw this slide 3 years ago, 2 years ago, in an article. It's a really good article. It's about 14, but it talks about everywhere that GLP-1 works in your system and why we get the results that we do or the side effects that we do, right? Let's walk through it. Starting at the top, the brain, of course, works in that hedonic center, less intake. Also, look at the second one, decreases water intake. When you're not hungry, you're not thirsty, right? So really put that on the list to drill into your clients. Increases neuroprotection, increases neurogenesis. I love that. Decreases inflammation of the brain, makes us smarter. Heart and blood vessels, increases the glucose utilization. Good, we want it used, not stored. Vasodilatation, increases cardiac output. We have seen increased heart rates. We're talking about 2 to 4 beats a minute. It's not drastic, but anybody wearing an Oura ring, anybody who tracks that can really see that. The kidney, another really gold star right here, you guys. Look what it does. Increases diuresis, increases water loss, increases natriuresis. What's natriuresis? Sodium. So increases sodium loss through the kidneys. So less thirst. You're coaching them to intake fewer carbohydrates, fewer packaged foods, which is our source of sodium, right, in the standard American diet. And they're excreting sodium. It's a recipe for disaster called electrolyte imbalance, right? That is headaches, fatigue, nausea. So really, really talk to your clients about this. Tell them about this. And my clients, their instructions, ounces of water a day and at least 1 packet of element. We use element a lot. Decreases inflammation. Who has seen this? Like, oh my gosh. If I'm late on my dose, my fingers swell. I really, really feel it. This is really awesome. And that really helps in people with autoimmune diseases, Crohn's. We've seen a lot of positive effects. Skeletal muscle. So this, what's missing from here? Eats your muscle. It does not eat your muscle, right? Right? So increases perfusion and increases glucose uptake. What does that do? Helps muscles grow. So if you are eating the right amount of protein, you're doing the right amount of strength training, you will gain muscle on GLP-1s. Increases thermogenesis, increases brown adipose tissue. Don't we love that? Who doesn't want to have more brown adipose tissue? Why is it brown? More mitochondria, burns more fat. White adipose tissue increases lipolysis of white. Bye-bye. Like, take that away. We do want white adipose tissue gone. Liver decreases fatty liver, decreases glucose production, all good things. How many have seen resolution, if not vast improvement of fatty liver in their clients? Absolutely. Works great. Gut decreases motility. Yeah, we know that for sure. Increases growth, decreases lipoprotein secretion. Good. Those LPSs, those are your inflammatory gut stuff. Increases insulin from the pancreas. We know that. Look at this. Increases beta cell proliferation. It makes beta cells. And this is one of the reasons why if you test lipase, your lipase is going to be elevated after you start GLP-1s. It's not a bad thing. So don't test lipase, okay? Because then everybody's going to freak out. Just don't test. Don't do it. Just say no. Decreases glucagon secretion and decreases beta cell apoptosis, death. Awesome. Makes them and keeps them from dying. Love, love. Win. Stomach decreases gastric emptying, feeling full for longer. That's always a good thing, except all of those billions of people who are on PPIs, right? And so now we have no acid. So we just have food sitting there not getting digested. That's when we get heartburn. That's when we get sulfur burps. That's when all of that happens. So and it also decreases acid secretion in the stomach. So if you're blocking it or if you're decreasing the secretion, you're going to get that problem. Digestive enzymes, you guys. Every patient, every meal, digestive enzymes. What else will that do? Help them break down their proteins for absorption, right? You're eating, trying to get them to eat a lot of protein, but if you have decreased acid secretion or you're blocking it, what happens? You're not getting your protein broke down into amino acids for proper absorption. You might be eating 150 grams and absorbing 90. This just shows the difference. Here's your GLP-1, and then they went and added GIP. So what is GIP's mechanism? Increases insulin secretion, glucagon secretion, decreases appetite, probably not that much involved in weight loss as far as like your decrease of adipose tissue, but it does increase triglyceride deposition. So I see why we don't use GIP by itself. And then all of this side over here, which GIP acts on, has really no help, except look at this at the end. Love this, bones. The previous slide doesn't talk about it, but we know that we can increase bone density. It helps to increase bone density. Here's all the blah, blah, blahs. First, and I want to go back and say, I don't speak for any of these people. I'm not getting paid. This is all like clinician to clinician. So here's the current indications. We know that it just recently got approved for obstructive sleep apnea, cardiovascular risk reduction. And so I suspect more and more indications are coming, and I'll show you why here. So we know it effectively modulates glucose, metabolic benefits. Here's your neurovascular, going again, heart, GI tract, pancreas, reduction in major cardiac events. This is what was proven to get the FDA approval. Sleep apnea and obesity, that's kind of like duh, right? But everybody that has obstructive sleep apnea is not obese, but probably the inverse is true. Tirzepatide, mostly that's the one with the approval. All right, let's talk about side effects and safety. This is what's TikTok famous, right? Everybody, I saw on TikTok, common side effects. We've all seen it. Who's seen GI side effects? Yes. Who's seen the burping we were talking about? Absolutely. And then injection site reactions. Yeah. Little bit of if you have an injection site reaction that looks like this, super localized, clinical pearl, the needle's probably not long enough, or they're not putting it all the way in, because it has to be an under the skin, not in the skin injection, right? And see, some people are a little needle shy and they're just kind of like, I'm not sure, I'm just gonna try, and they're not getting it all the way in. So really use a 5/16 needle, not a 1/2 inch, and tell them just put it all the way in. I always have them pinch up the skin too, so they're afraid they're poking their intestines or something. I was like, good luck with that. But my background is trauma and emergency medicine. I've seen how much it takes to get into the abdomen. Not so common, but we do see this. So depression, suicidal ideation, and loss of joy. Anybody seen that? Yeah. I had a person who became frankly suicidal within 3 days of her first injection. Never had that in her life. And so really talk to your clients, especially if they have a history or if they're taking antidepressants, ever had suicide attempts in the past. It doesn't exclude them, but really you do want to know that and tell them, because it doesn't mean they can't take a different one, but you really have to be monitoring. Loss of joy, because it hits that hedonic center of the brain, right? It takes the joy out of eating, right? So if you're one of those who are, like, lack of a better term, hyper responder, it might take the joy out of life in general. So really ask those questions. We really we owe our clients, our patients, that respect. Anybody seen this? Painful burning skin problems? Yeah. Feeling like they have bruises all over their body, painful to touch. Usually resolves within about 3 months if they'll stick to it, but sometimes it doesn't. Sometimes it's only in one spot. It seems to start on the upper body. Is that everybody's experience, or anywhere? Just shout it out. Yeah, anywhere, upper body. I agree. Most of the ones I've seen are upper body, but it has moved to like whole body down to the thighs, especially like wearing clothes is uncomfortable. Guess what? there's case reports about that. So I bet if we put it out there in the GLP-1 prescriber world, we would find a lot more. But there definitely is case reports of this. Not dangerous, annoying for sure, but this was only 4 cases. Most of they have this fancy scale they rated them on, but some of it went away. Some people stopped it because they didn't like it. Here's your rare but serious side effects. So we do need to be aware of this. Again, your contraindication with pancreatitis. If they've had a provoked pancreatitis, that doesn't put them on the absolutely excluded. If they have a pancreatitis that seemingly came out of nowhere, I would take pause. C-cell tumors, especially thyroid, and blindness. Not really seen, but we do have those reports from ophthalmologists who specialize in type 2 diabetes, arteritis, that kind of thing, and they have seen what they feel is an uptick. But they're the specialists that everybody gets referred to, and more diabetics are getting put on this. So the weighted evidence is not strong, but it's something to be, if somebody mentions vision changes, it's possible, not probable, but possible. So really to mitigate these strategies, patient selection, monitoring, dosing strategies, we're going to talk a lot about this. You guys, I'm sorry, you have to deal with me 4 times today. So we'll talk a lot more about this in the clinical application of it. Pharmacokinetics, the differences in the half-life. Remember semaglutide half-life, 160 hours technically, which is almost 7 days. Tirzepatide's only 5 days. So if you have clients saying, oh, I start feeling hungry like 2 days before my next shot, it's the real thing. So we can have dosing strategies that we can use to minimize that. Of course, we are always tailoring to our patient's needs. We don't automatically escalate. Again, clinical application later today. More than just weight loss. So these are all of the, I'm just going to run through some really quick. I don't have a timer, so I have no idea where I'm at in this. I'll make up your 5 minutes. Thank you. Expanding indications. We talked a little bit about this, non-alcoholic fatty liver disease, liver inflammation, so just anything. I had a client say, my liver's covered in cysts. I never knew if that was fatty liver, what she was talking about. She's like, but they're all gone now. I'm like, great. Awesome. Alzheimer's, neuroinflammation, they call dementia, Alzheimer's, type 3 diabetes, right? So insulin resistance of the brain. So let's say our brain is more adequately using the glucose, which it absolutely needs to be powered by. That's pretty exciting. Anybody use a GLP-1 for binge eating disorder? Anybody have that experience? Yeah. It's a special clinical management. Like you have to really be on top of it, but it works. It works. It works episodically or it works continuously. So however you decide to dose that with your clients, obviously off-label, not FDA approved, but when you feel binge eating is like they never feel full, right? You could just eat and eat. Think about any of you are using GLP-1s, you can't just eat and eat because you get that signal real quick that you're done. So breast cancer, look, semaglutide decelerates the growth and progression of breast cancer. So one of the risk factors for breast cancer is what? Obesity, right? Why? Because obesity is very inflammatory. And so 15 different cancers, obesity increases your risk for 15 different cancers. So it makes sense. This makes sense, right? When we put it all together, you're like, oh my gosh, this is like the magic wand. It's not, it's only a tool, but it's pretty exciting. And full disclosure, it was a mouse study, but doesn't always translate, but it's exciting to look into. Who knows? This joint pain, you guys, back pain, knee pain, hip pain. Have you seen this with your patients? Life-changing for some. I don't like to use that word regularly, but if you're looking at a knee replacement and all of a sudden it's pretty exciting. Pregnancy health. So this is not taking it during pregnancy, This is preconception health, right? So there's studies out there now that are telling us that your genetics tendency toward obesity can be linked back to your parents' preconception weight. So anybody who's even thinking about getting pregnant, both need to get in shape and you will increase the likelihood of the good genetics for your child. And then also we know that if you're not overweight during pregnancy, it decreases your risk for hypertension and gestational diabetes and all that. Life expectancy, this moves into the longevity space. Who practices longevity medicine? Yes, you speak my language, love it. Addictions, absolutely. I'm 100% convinced there is going to be a peptide to treat addiction. Suboxone is going to be wiped off the map, I feel, and because we know the area in the brain, right? Using AI now, what they're doing is looking at the structure of those receptors, and then you can create the peptide that fits into that receptor for that particular addiction. So super exciting. Skeletal remodeling, this goes back to the bone health. Part of this, I feel like, first of all, you're getting weight off people, they're getting active, you're coaching them to eat more protein, their strength training. So it's a win-win because all of that is going on. HS, anybody treat patients or have seen or know people with HS? It's devastating. I also practiced in dermatology for 15 years, and basically like, okay, here's your antibiotics, you get an abscess, we'll drain it, I hope, and here's a deodorant. It's horrible. It's really, really interrupts. It's a big quality of life issue. So, but this makes sense, right? Anti-inflammatory, autoimmune, HS is autoimmune. So, and a lot of people with HS are overweight. Lipid profile absolutely does great for cholesterol, triglycerides. I don't monitor labs in my practice, but I always tell them to have it done, especially if they're already on a statin. We don't want cholesterol to be bottom of the barrel, right? We need brains. We need to be able to make cells and hormones. So don't be sure that they have that monitored regularly by their prescriber, whoever's prescribing that for them. So we already talked a lot about mechanism of action. We won't go there, but distinct functions in inflammation, oxidative stress, insulin-sensitive musculoskeletal adipose tissue, and possible applications and protection from infections and anti-aging properties, core molecular mechanism involved in obesity, diabetes. So it's just like, it doesn't stop. It seems like it doesn't stop. This is the important part to know as a clinician, that when you are looking at patients who come in and say, this is not working, you're talking about liraglutide, obviously one of the older ones, reach its maximum efficacy by 17 weeks. That's actually pretty good, but liraglutide, we know, a daily, right? And so when you look at retatrutide, 1 year, 11 kilos, it takes a long time. All of the FDA approval studies were 68 weeks. So you're not talking about losing 20 pounds in 2 months. You're talking about 18 to 22% of your body weight in 68 weeks. So set them up for the long game, right? Tell them we coach a pound a week, like that. We're looking for an average, not a pound every week, period, an average of a pound a week. And we know that a weight loss curve isn't down, it's a journey. And so just be sure that they realize there is also significant negative correlation between age and weight loss effect. And so, but BMI had no significant influence. So age can be a factor, although I'll show you case studies of people in their 70s doing well. We will do a panel later today, so we can do questions then. There's Adam. Caught him out of the room. Love it. Okay, let's take questions. Yeah. I like pure encapsulations. The one, it has a lot of different, it has your amylase, your cellulase, all of that, as well as betaine HCl. So that is the like your stomach acid. So enzymes and acid. Yep. Sure. Yeah, absolutely. We do use probiotics. I don't like people to monocrop with their probiotics though. So it's important that they either take a month off, or I tell my clients, because I use full script, pick a different one. Every time you're starting a new bottle, choose a different one, because there's different strains, there's different amounts. And so you don't want to just keep putting the same 2 lactobacillus in all the time, because you can definitely create a dysbiosis that way. Can anybody see comments on live stream? No. Yes. Good question. She was asking if I'll do it for the live stream. Sorry, first live stream. The first one was about what brand of digestive enzymes I use. And then second question is, do I recommend discontinuing H2 blockers? If the person has been on an H2 blocker for years, even though the indication is like 2 months, they'll never get off of it. They've shriveled those cells, like atrophy has taken over. They'll probably never get off of it. So if they are casually taking OTC, Prevacid, whatever, I really encourage them to discontinue it. I don't know, that people get an emotional attachment to these things. Have you seen this? Like, don't take my H2 blocker. So weaning them, using digestive enzymes, like crossing over, it's like, hey, if you actually digest your food, you won't need this. And so there's, my doctor said I have to take it. Okay, I don't argue with that.
Tirzepatide, like 5-day protocol, 7 days.
I will touch, the question is with the half-life of tirzepatide being different, do I do anything different with my dosing? Yes, sometimes, and. So I will cover all of that in the clinical applications later today. Yes. I don't have the question was using PPIs or H2 blockers episodically. I don't have a problem with it. I prefer that they start with like Tums, like just chew a calcium carbonate and see if that helps, rather than a pharmaceutical that's going to shut off. And unless they really have a problem, then yeah. Mostly get them into the digestive enzymes, get them to eat smaller meals. Don't drink fluids with your meals. That expands the stomach, dilutes what digestive enzymes they do have. So it's kind of a problem because you're trying to get them to drink more, but don't drink, because what you're doing then is filling your stomach up with water. And then imagine it like that. Okay, then you're putting food in there and it's just sitting there. And so you can get reflux. Liquids should pass through faster technically. So, but I do really harp on the digestive enzymes, and those who are resistant and then finally do it, they're like, oh my gosh. So yeah, just really encourage that. Yeah. The sulfur burps, it's the same thing. I just small meals, protein first, don't drink with your meal, don't lay down, don't eat within 3 hours of bedtime, don't lay down, and then the digestive enzymes. And you can use some anti-gas if that's really what they feel like they need. I wouldn't do it on a regular. I don't want them to feel like they have to medicate themselves with something that the GLP-1 caused, right? We have the strategies that we can do it. Sometimes smaller doses more frequently. Oh, uh-oh, all three, oh, good. Yay, you have the mic. Yeah.
Can you speak about hair loss as a side effect?
Yeah, that is a lifestyle issue of protein, and then again, protein. Not all. Obviously, the change of how they're eating, and a lot of times at the very beginning, they're like, get that really strong anti-eating urge. And so it's a change. You got a telogen effluvium about 3 months after starting, after childbirth, after surgery. If they are eating adequate protein, it will be fine. And other hormones balance too. You have to then think about thyroid, ferritin, all that stuff, just to make sure.
I've got a question from somebody that's virtual.
Thank you.
What do you recommend on patients on PPI and GLP-1 medication with severe heartburn?
Yeah, that's where we were talking amongst ourselves about that. Sorry, live stream, I didn't want to cut you out. So what we do is, again, using those digestive enzymes. If they really do have it, there are some people we talked about that have been on them for years, they'll never get off of them. And so if they're on them, but still use digestive enzymes, because that's what they need. That's what we need to digest our food. Adam, over, yeah, right there, glasses.
So obviously, like on social media, everyone's cortisol this, cortisol that, right? And when we see these adrenal adaptations, a lot of people, it's not, I've noticed just anecdotally, it's not usually high cortisol, it's low cortisol, because that at that point, now you're starting to manifest those adaptations. Yeah. What is your thoughts on addressing those higher level, like, several phases in adrenal adaptations while also implementing a GLP-1. Obviously, we don't want to impact anything that's because people are already usually under eating, under consuming nutrients, they're undernourished. Adding in a GLP-1, but that's also subsequently potentially helpful for all these other things. What are your thoughts on that and advice on balancing or assessments of when to sort of like how to pre-qualify people for moving them into some type of GLP-1 treatment if they're on that spectrum of just like high chronic stress due to anything really?
Yeah, good question. Nobody in here has stress. So
Yeah.
I don't even know how to answer that. No. So what we do is talk a lot about lifestyle. So, you know, with dysregulation, you can't give them a pill for it, and they have to walk the walk. You have to get that morning sun. You have to get to bed and get up at the same time every day. You have to do all that. Your attendance, if that's what you're using in your protocols, and food is a signaling molecule too. So if you're using semaglutide, then you really have to be sure that they have their circadian rhythm dialed in with their food too, and they're not trying to get it all in at 9 o'clock at night. And really telling their bodies they have to really have a tight schedule. We are circadian beings, whether we like it or not, and it's really hard to fight it. And then stress. So stress, I never say stress reduction. Some people just feel like they can't do anything about their lives. They're not in control, but they can work on stress management and whatever that looks like for them, a spiritual practice, a meditation, a journaling, a cold plunge, cryo, like a lot of different things, and just really trying to get them into a routine, and then they'll feel more in control too. When you're in a routine and you're not just getting up going like, I don't know what I'm doing today, you'll feel more in control. Adam is running with the mic.
What do you recommend for constipation?
Magnesium citrate, and lots of it. Yeah, I tell them start with 2 capsules at bedtime and increase every night to desired effect. If it's more of an effect than you desire, then back off by 1 or 2 capsules. Yeah.
Have you ever had anyone that, along with loss of joy or anhedonia, has had complete loss of their sex drive to the point it's disturbing for them in their relationship? And if so, what do you do about that?
Yeah. So that is part of the loss of libido, loss of joy in life for sure. And it can happen. So changing peptides, it could be a good possibility. Changing dose, lowering it, or changing how often. I'm usually going small more frequently, and making sure, especially peri or menopausal women, making sure their other hormones are all aligned: testosterone, estrogen, progesterone, et cetera, estradiol.
How important is that when you talk about like hormone regulation with this? Is that something you look at first before you then get on to
You're
like
doing
a
my
GLP-1?
clinical application talk.
Oh, sorry. Oh, sorry.
We will talk about hormones. Yes. Answer, yes. It's super important. Super important. Behind you, Adam.
Do you have any personal experience in using GLP-1s to decrease seizures? I have a patient who's a late teen who actually, she's not a patient yet. I was having a consult and she's at the max of her Tegretol. And the mom is like, hey, what about GLP-1? And I'm like, I am not a seizure doctor. Anyway.
Yeah, well, good call on that. It is important to note that if you think there could be a good fit, but you're not comfortable with it, then ask around colleagues. Maybe there's a progressive neurologist in your area. Doubt it, but or endocrinologist. Doubt it. If you feel comfortable, if you feel like you can talk them through an exhaustive, informed consent, and GLP-1s are safe. Semaglutide is safe, and so I personally would have not had experience. I would be willing to work with a family on that.
Well, I think it's good to understand also that GLP-1s in their inception were not made for diabetes or even weight loss. They're actually studied for neurological conditions, for brain. So you have to look at the foundation of what the GLP-1s are actually doing based on their mechanism of action, helping with inflammatory issues, regulating that. I mean, we know neurosymptoms like seizures. My wife had neural Lyme, so she dealt with seizures constantly. And so I had her on semaglutide, and it did help. So I think that is something, like Rhonda said, it's something worth. Yeah. And so if anybody is asking, if you're looking for a patient, first place I always go is just go to like PubMed, just start researching GLP-1s for, you know, neuro seizures. You're going to find something.
Go to Perplexity.
There's some questions online about microdosing.
Yeah.
Yeah. Yeah.
I don't even know what it is.
It's a fad term that's being used
It
right
is
now.
a term. It is
yeah.
a term. You're right. It is. But is it a thing? And so I really want to talk about that in the clinical applications.
Everybody online?
We will.
That will be talked about. in
I
the
will.
clinical
We will
applications.
address it. Another TikTok favorite.
You actually have like 20 minutes.
Well, I talked too
but-
fast.
no,
Sorry.
That's perfect.
How long did you give
You
me
guys
for
are
this?
enjoying the Q&A, right? This is where we're really
I'll
grabbing the
keep- I mean,
knowledge. Yeah.
I'll keep answering if you
Any
keep
other
having.
over here? No, you can't
Bye.
have any more. No.
We're gonna have to give out question tickets. You only get.
Obviously, with the impact on intestinal motility, how things are absorbed, digested, et cetera, what is your experience, thoughts on GLP-1s for individuals who have autoimmune digestive disorders? Is that something that would be inappropriate? And I'm sure if it is, you maybe we'll talk about it, but just your general thoughts on that
Yeah,
for
it's
those
amazing.
population.
But I would also combine with BPC 157, KPV, lorazepatide. Like there's a lot of good peptides out there, you guys. And so the combination, I have a couple of ulcerative colitis, IBD people who definitely have used the word life-changing. One that went from stage 4 to stage 1, one that went undetectable. So for sure, in combination with other things. So really work your way back into the mechanism of action and see where we can affect, like where are these receptors, what is causing this? And that will set you guys aside as practitioners because you're treating the true root cause, right? And not just like, oh, here's your PPI.
You talked about digestive enzymes at the beginning. What would somebody's asking? They'd love to hear more about the recommendations for digestive enzymes. Like which ones? Like, do you have a specific brand?
Yes, in my practice, I use Fullscript. So on there, I use Pure Encapsulations, Digestive Enzymes Ultra or something like that, I believe it is, but it's the one with betaine HCl in it. And I have them do 2 capsules with every meal. Every time they put, especially protein in their mouth, they should be putting digestive enzymes. And if they still don't feel like that's working, you can increase it. Again, digestive enzymes are safe. If you take them and then you get a heartburn feeling, that's too many. So technically there have been studies about working your way up until you get that intensity and then you decrease it to see how many digestive enzymes you actually need. So, but usually 2 per meal. That's great.
Can you use semaglutide while breastfeeding?
Not recommended. Yeah. The problem I see with it is that when you're breastfeeding, you're feeding 2 people. And if you're not eating enough, you're not feeding yourself, nor are you feeding your baby. So I would not kill the appetite of any, especially, or the thirst, like taking in foods. Behind you, Adam. Oh, sorry.
That's right.
More live stream.
For PCOS patients,
Mhm.
if they lose, for example, 40 to 50 pounds, how do you taper them off? If they lose 40, 50 pounds and once they get off the medication, they feel inflamed,
Yeah.
everything's coming back. How do you approach them?
That's a great clinical applications question. So yeah, we'll talk about titration and dose de-escalation this afternoon. And really, side note for anybody using these with PCOS patients, they don't believe they can get pregnant. I have 6 PCOS babies in my practice, so they can get pregnant because they've been told you'll never get pregnant, but obviously they've never used a GLP-1. So really talk with them about that. It's not dangerous. I just tell them if you think you're pregnant, don't take it until you know that you're not. And if you are, then just stop taking it. Adam's picking people.
So I've had a lot of patients come to me. I just had a lady this week. She had maxed out on semaglutide and she was going to a med clinic, which is fine, but
Yeah.
she had maxed out on tirzepatide and
Mhm.
she had not lost any weight.
Mhm.
So I see this a lot. And what do you do? I mean, she was on a very high dose of Vraylar and a very high dose of Seroquel. And I said, I'm sorry, when some people are on these antipsychotics and antidepressants, I still do not see them losing weight. And I'm like, I don't want your money. Like there's nothing, if you
Yeah.
want to lose weight, this is what's causing your 80-pound weight gain. but there's really nothing we can do when they're on those like antipsychotics and antidepressants, because I can't get them. I mean, they don't lose anything, even with dietary changes and increasing activity.
Yeah, and there's about 10% that will be non-responders to this. And so, and the male population has a higher percentage of non-response. So I don't know if you've seen that, men just don't lose weight. I just thought it was because they just weren't on the boat and doing the lifestyle things, but men seem to not respond as well. So that being said, there are other things that mess it up for sure. Like medications, antidepressants. How many perimenopausal women get put on antidepressants today for anxiety when they really should be put on progesterone? But that's another talk for another time. So yes, antidepressants, and that also has to do with the libido killing too. Whenever somebody's having a struggle, I go through their med list and I line it out for them. You're on this, and this is a possible side effect. And because they will always blame your peptide, right? They will always blame the peptide because their doctor didn't tell them that their antidepressant would cause this. Their blood pressure medicine can cause erectile dysfunction, and they're going to blame it on your semaglutide. So really work around into that education with your clients for sure.
Yeah, and I would say even for that, it opens up an opportunity as clinicians to address the root cause of an issue. I mean, you're talking about people being on antidepressants. It's, well, why are we there? We talked about stress earlier. So other modalities and things which you're going to be learning about this weekend could help resolve some of those issues, because non-responders, it's not just because something's not working, it's because something is hindering that. Because the body's made to be able to do these things, but when it's carrying that junk and that baggage, whether that's a pill, medication, I mean, sometimes just getting them to walk will decrease the stress, which will,
increase your insulin sensitivity. Yeah.
Any other questions?
Yes. She's used up her question tickets. No, I'm teasing.
Oh, so they can hear.
Yeah.
Okay. Well,
Don't cut out.
I'm
the
not quite
live
that loud.
stream.
So SIBO, right? Again, I deal with a lot of like, oh, I don't have gut problems. And then they're like, yeah, actually I do. Yeah, no, I could have told you did. So SIBO, whether it's confirmed via some form of testing or just screening and okay, you have really consistent biofeedback. Let's take a look, maybe get like either like some form of diagnostic, address it prior or concurrently with the use of a GLP-1, or is it context dependent in your opinion?
I think the context dependent is the right answer, especially depending on how severe it is, because GLP-1s will can positively, but they can also negatively affect microbiome. And so if they're always taking one strain of probiotics, so you have to really evaluate what they're currently doing. How do you think they got to where they are? If it can be corrected ahead of time, that would be awesome. Some people just want to get that weight loss, and you can tell them, we'll start this, but we have to really be careful. You have to monitor yourself. You have to know your symptoms, and we may have to back down or pause while we get the intestinal condition addressed.
Awesome.
Did we do it?
Yes, we did it.
Thank you, everyone.
Who's excited to listen to her again later today, right? Thank you, Rhonda.